Hello, my name is Emily Juzwiak, and I'm a fifth-year PhD candidate working in the lab of Dr. Hal Dietz at Johns Hopkins University. When I decided to go to graduate school, I wanted to use my undergraduate degree in genetics to study cardiovascular diseases. I wanted to do research that would directly impact patient care. So I started checking out research going on at Hopkins and came across the work going on in the Dietz lab. The first time I spoke with Dr. Dietz, he introduced me to VEDS in general, as well as the new mouse data that had come from the lab. I was hooked. There was so much we didn't understand about this genetic condition, and I wanted to be a part of the team that helped figure it out so we could offer therapies for patients. One of the things that really interested me most was the observation that male patients with VEDS had a higher likelihood of having an event during puberty than their female counterparts. Our VEDS mice support this observation. I'm showing survival data of our VEDS mouse model with age of mouse in days on the x-axis and percent survival on the y-axis. Anytime a mouse died from a vascular event, you'll see a decrease in the survival lines. Our male VEDS mice in orange have more vascular events during puberty compared to the female VEDS mice in black. The red arrow marks the time point where VEDS male and female survival split. This point is the beginning of mouse puberty. Because males are affected during puberty, it led us to wonder if there is a role for androgens in VEDS. Androgens are hormones that contribute to male secondary sexual characteristics, like increased body hair and muscle mass. Androgens are present in both males and females, but they are much higher in males. Androgens peak at the time of puberty in both sexes, but this increase is higher in males. And the androgen receptor is expressed in the aorta. To understand if androgens were influencing VEDS, we measured how much androgen receptor was present in the aorta of our VEDS mice. We saw that adult male and female VEDS mice in green have the same amount of androgen receptor. This means that there is not simply more androgen receptor that's causing disease in males, but that androgen receptor may be more active in male VEDS mice during puberty compared to female mice. To test this, we gave our VEDS mice a drug that strongly blocks the androgen receptor from working. This drug is called bicalutamide. Bicalutamide is shown in blue, and bicalutamide improves survival in male VEDS mice, but not female VEDS mice. To be completely sure that we could study androgen receptor function in VEDS, we deleted the androgen receptor for VEDS mice and monitored survival. The VEDS mice who are missing their androgen receptor are shown in red. We observed that androgen receptor deletion provided the same level of protection as bicalutamide did in male mice on the right. This made us confident that androgen receptor function is contributing to vascular events in puberty. We detected the androgen receptor in untreated VEDS mice in orange and in bicalutamide-treated VEDS mice in blue. When we deleted the androgen receptor from VEDS mice in red, we saw that the amount of androgen receptor went away. These findings were expected and tell us that the survival improvements we've seen are because we inhibited androgen receptor function. We checked to see that androgen receptor inhibition did not alter blood pressure or pulse. As bicalutamide and androgen receptor deletion are not practical for use in the clinic since blocking androgen receptor function disrupts normal sexual development, we turned our attention to spironolactone, a widely used diuretic that is used to treat androgen-related conditions such as alopecia and acne. Spironolactone's side effects include mild gynecomastia in males and menstrual irregularity in females. When we gave spironolactone to our VEDS mice, we saw that it drastically improved survival in both female mice on the left and male mice on the right during puberty. To our surprise, spironolactone seems to work even better than bicalutamide, suggesting that it is doing something new. Spironolactone works by blocking the function of the androgen receptor and another receptor called the mineralocorticoid receptor. Because spironolactone targets two receptors, we wanted to know if its protection was due to its androgen receptor blocking abilities, or its mineralocorticoid receptor blocking abilities, or because it blocks both. So we gave our VEDS mice a drug that only blocks mineralocorticoid receptor function. This drug is called eplerenone. Eplerenone is a blood pressure lowering medication that has been used to treat heart failure after a heart attack. The side effects of eplerenone are dizziness, muscle cramps, and diarrhea. However, because eplerenone doesn't block the androgen receptor, the mild gynecomastia in males and menstrual irregularity in females on spironolactone are less likely to happen. Eplerenone treatment in gray provided intermediate protection compared to spironolactone in purple and untreated mice in orange. We tried another specific mineralocorticoid receptor inhibitor called finerenone. It was recently FDA approved for use in type 2 diabetes. This table shows that finerenone is more specific for the mineralocorticoid receptor than spironolactone or eplerenone. In a small pilot trial, finerenone provided almost complete protection in both females and males during puberty. We observed that doses of spironolactone, eplerenone, and finerenone did not alter blood pressure in our studies. So I've shown you that drugs that specifically block mineralocorticoid receptor function have therapeutic potential in VEDS mice. We are currently working to understand why blocking mineralocorticoid receptor function improves VEDS mouse survival. In conclusion, blocking androgen receptor function with drugs or by deleting it from the DNA improves survival. Bicalutamide modulates only androgen receptor function, leading to survival improvement. However, it impacts sexual development. Spironolactone provides the most protection during puberty because it blocks both mineralocorticoid receptor function and androgen receptor function. Eplerenone and finerenone only modulate mineralocorticoid receptor function, and this will not impact sexual development, and it still provides protection in VEDS mice. Classically, it takes 10 to 20 years for a new drug to make it through all of the preclinical and safety trials needed to become FDA approved. Eplerenone and finerenone are already FDA approved and known to be safe, so we can shorten the time it takes to get them to patients. We need to do more mouse mechanistic work on these two drugs, but if they proceeded to a clinical trial in VEDS patients, we could know the results in 3 to 5 years. Thank you so much to our wonderful sponsors and for the other members of the DEETS lab. Thank you for listening.